Hi, this is Dr. Bhargava. In this short video, I have three interesting cases to share with you: renal cell cancer mets, prosthesis loosening, and neuroendocrine tumor metastasis to the ovaries. Let's get started. Here's our first patient. We are looking at anterior and posterior whole body images. This patient had history of renal cell carcinoma, and the scan shows multiple foci of intense uptake suggestive of osteoblastic bone metastases. So typically RCC mets are lytic, but even in lytic lesions at the periphery, there is osteoblastic activity. So here we see a focus in the skull. Since it's anteriorly located, it's not as well seen on the posterior image. Then we see multiple rib lesions. When cancer goes to the bones, especially the ribs, the metastatic foci are linear compared to a spindle-shaped uptake when there is a fracture. So there are multiple rib metastases on both sides. Here is a review article on the topic, skeletal metastasis in renal cell carcinoma. And the authors conclude that the incidence of metastatic renal cell carcinoma is increasing. Overall prognosis of patient with advanced RCC is poor, emphasizing the importance of early detection and prompt treatment of primary lesion in its early stage. Here is another article. This is a research study comparing whole body bone scan to whole body MRI. And here the authors conclude that whole body MRI is a more sensitive method for detection of bone metastasis in renal cancer than bone scintigraphy, and also allows the assessment of soft tissue disease. Let's move to our next patient. This patient has history of hip prosthesis on the left side, and they were being evaluated with a three-phase bone scan. On the top, we have blood pool images in the anterior and posterior projections, and at the bottom, we have delayed images in anterior and posterior projections. And on the anterior image, you can see here that there is increased periprosthetic uptake at the bone prosthesis interface along this left hip prosthesis. This is a non-specific finding and may represent either loosening or acute osteomyelitis. The next step could be either a gallium-67 citrate study or a indium-111 WBC scan along with a marrow scan, which was performed and it was negative. This patient also had plain films that show this lucency along the prosthesis in two views, which is suggestive of loosening. This is a great review article on the role of nuclear medicine in the diagnosis of infected joint replacement. Here, the authors say that bone scintigraphy is useful as a screening test despite an accuracy of only 50 to 70%, because normal results essentially exclude a prosthesis complication. In addition, the addition of gallium-67, a non-specific inflammation imaging agent, improves the accuracy of bone scintigraphy to 70 to 80%. The accuracy of combined leukocyte marrow imaging is 90%, highest among the available radionuclides. Its success is due to the fact that leukocyte imaging is most sensitive for detection of neutrophil-mediated inflammation. Here's our next patient. They were diagnosed with small bowel carcinoid, metastatic to mesenteric lymph nodes, and they underwent a dotatate PET-CT. Here's the rotating image. This rotating image shows physiologic uptake in the pituitary, uptake in the spleen more intense than the liver, and excretion from the kidneys into the urinary bladder. This is their primary in the small bowel, and this is mesenteric metastatic disease. The mesenteric lymph nodes are seen here on the CT with intense uptake. There is a focus in the left side of the pelvis, which is right here. And it's not very clear, but this focus is in their left ovary. This patient was treated medically with sandostatin injections, and they came back for a follow-up study. Here is the rotating image from the follow-up study. Now we can see that the disease has worsened. There are multiple foci of increased uptake scattered in the abdomen and pelvis, consistent with peritoneal carcinomatosis. This is their mesenteric lymphadenopathy that shows intense dotatate uptake. And here is their left ovary, which is now much larger. So this is a rare case of ovarian metastasis of neuroendocrine tumor seen on a dotatate PET-CT when the patient stopped responding to medical therapy and worsened and developed peritoneal carcinomatosis. I was surprised to find this article on neuroendocrine tumor metastasis to the ovaries, and here the authors conclude that neuroendocrine ovarian metastases are more prevalent than previously reported and associated with significant morbidity. Empiric oophorectomy may be considered for small bowel neuroendocrine tumor patients and strongly advised in carcinomatosis. Thank you for watching.